My topic is not a video session because time constraint. I avoided videos. Minimally invasive hysterectomy is a formidable surgical undertaking with a steep learning curve and mobility is very high. So we are looking into the morbidities, complications and collateral damages, and we'll discuss how we can circumvent the collateral damages basically. These are the common complications as per multiple studies. Pulmonary morbidity is the commonest. Anastomotic leak, vocal cord paralysis, chylothorax, tracheobronchial injury, necrosis, bleeding, and chance of splenectomy or splenic injury. So we look into each one by one. See, pulmonary complications, as I mentioned, is commonest among minimally invasive hysterectomy complications. And origin is multifactorial, and most of the factors can be modified, as in marked in red color. The factors can be classified into patient-related. Lung diseases can be more optimized. Smoking, alcohol can be stopped. Diabetes can be controlled. Nutritional support preoperative either by stenting and feeding or feeding gynostomy tubes. Please avoid feeding gastrostomy. I have seen many occasions where gastroenterologists have performed a PEG and we find it difficult. So once the patient is having a chance of surgery, please avoid feeding gastrostomy. Disease-related factors you cannot modify much. Surgery-related, of course, this is the area of our surgeons. It can be a single lung or two lung ventilation. I'll come to that later. Handling of lung tissues, extensive lymph node dissection can damage even nerves and aspiration pneumonia. These are all increased to the pulmonary complications. Then injury to the tracheobronchial tree can have a devastating effect post-op. And post-operative problems like nutritional management, again, hypoalbuminemia, volume control, infection, again come to the nerve palsy. So regarding the position and ventilation, whether it has an effect on pulmonary complications. Of course, prone and semi-prone positions can have a two-lung ventilation. Recently, papers have come up with semi-prone position also comparatively compared to the prone position. So you can do a two-lung ventilation along with the semi-prone also. But lateral position need a single lung ventilation and two separate lung ventilation and modified ventilation therapy. Optimum position of the ports also important. I'll come to that. So this is a position. Recently, this is a prone and a semi-prone position. You can see the different positioning, and depending on that, see. So you can see the classical prone position. You can see the port, which is placed basically in the posterior axial line and the scapular line. And if you go for the semi-prone position, you can modify the port a little bit into the posterior axial line and mid-axial line. So depending on that, see, when you are improperly positioned port and you are introducing the instrument, that can itself damage the lung tissue when you are entering multiple times without any visual, because most of the time it's not possible to visualize the port entry because of the limitations of the thoracic cage. So you have to be careful with the port positioning itself. Or if you are positioning the port below, then the lung tissue will come in between the mediastinum and your camera, so that you have to compress the lung and you have to handle the lungs more. That can damage the lungs. So this is a prone and semi. There are Sundays which come up with comparative result with two lung ventilation in semi-prone position. Coming to the prone position related damages, there are extensive studies and papers coming up with prone position related damages. But most of these damages are when there is a prolonged surgeries, like in spine surgeries, other surgeries. But in some cases, like in our thoracoscopy or robotic or laparoscopic esophageal surgery, you can have some damages. And then highlighted damages are reported in the more commonly in the literature. along with the esophageal surgery. So this is one device we are using to protect the airway, facial injuries and pressure injuries, even the eye. The eye can be pressed along to the because of the prone position. This is a camera, mirror here. You can see this is the initial position. We fit the helmet here. Then another part of the helmet is here with the mirror here. You can see the mirror so that you can see the position of the airway, and you can always monitor. Even sometimes there is a camera also, so you can monitor the eye position of the eye and other things. One device can be used. So this is an extensive study and paper on the position-related injuries to the face and airway. Okay, there is again, complication can be a thorax injury. Rib fractures and intercostal nerve damage are reported. Nerve pain post-operative is reported. Lung injury, of course, if you have first port, if you have not entering carefully, can damage hematoma, bleeding, pneumothorax. An adhesion should be divided sharply, no blunt dissection. These are the structures, vascular structures commonly encountered in the mediastinal dissection, and most of the time the injuries to the esophageal vein and bronchial artery are reported. The other major catastrophes and immediate conversion to the open procedure is required. Sharp dissection of the esophageal vein and clipping or stapling is the must. In suturing, better to avoid sutures. You can slip and bleed. Bronchial artery, short description is the bronchial arteries are two sides, right and left, and most of the time right is single and left side there are multiple. Most of the time two arteries are there. Right artery, most of the time we need division, and sometimes along with that it originates from the intercostal artery, so there may be bleeding. But we should be careful regarding the left side, because when you do a aortopulmonary dissection or recurrent laryngeal nerve left-sided dissection, you may damage the left-sided bronchial artery. That may be catastrophic, can lead to ischemia of the trachea. Of course, trachea and bronchus can be injured, mainly the membranous part. When there are multiple lymph nodes in the subcarinal area, that dissection can lead to injury to the membranous part of the carina. So avoid thermal injury, go away from the membranous part and can be immediate damage or delayed, and can damage, if there is a fistula, if there is a chronic or delayed injury, can communicate to the conduit and can form a fistula and set poor prognosis. Thoracic duct, another structure, important structure. Again, there is a debate going on, routine dissection or dissection only by involved disease, or there is no dissection. But there are complications if you divide and ligate chylothorax, nutritional deficiencies, fluid retention. Sometimes cancer-related, there is also debate going on. Cancer-related survival is better, or some studies shows there is a real benefit. Some studies say there is a immune-related reduced survival also. So identification of the anatomy is important if you are planning to dissect. But most of the time, I avoid the thoracic duct dissection. But you can visualize the thoracic duct by giving an olive oil at least 8 to 12 hours before the surgery. And there is a recent method like ICG. You have to give to a lymph node in the inguinal region, and you can trace the thoracic duct during surgery. And recently there is another method. You can inject subcutaneous ICG and trace the duct. This has the 20 years experience. They say middle third lesions have more injury to the thoracic duct. This is a study says that there is only oncological benefit if there is a T1 lesion, and better to avoid in advanced diseases. Identification, again, this is a paper I told you, subcutaneous injection into the inguinal region can also show the thoracic duct. That's a paper. Nerve damage of phrenic nerve is actually is more anterior and it's on the superior vena cava, so it may not be damaged unless you do a more anterior dissection. Recurrent laryngeal nerve, will come to that more. Right-sided nerve is more easier to trace. You trace the vagus nerve below the subclavian and trace it up. Any branches going to the tracheoesophageal group should be taken as a right nerve. Left side is a little bit complicated. You can either dissect the nerve in the later part of the surgery after mobilizing the entire esophagus and hook it up the esophagus above out with either outside loop, or you can do with I usually do the esophagus is fixed to the pleura, so that you have a space here and you can, without any additional instrument traction, you can trace the lymph node in that groove between the trachea and esophagus. The esophagus hooked up and you can trace the vagus, dissect the vagus here. That is another method. So you can use either hook the esophagus up or stitch there, and easily you can dissect there. This is a nerve monitoring for during the surgery. Recently, the nerve monitoring device by Medtronic can be modified into use into the minimally invasive esophagectomy. You can use this. This is the electrode attached to the endotracheal tube, and you can monitor during a handheld. This can be modified for a laparoscopy also, put into the suction tube and extend the length so that you can dissect the lymph nodes without fear. So there are many studies, monitoring can be done even without any prior experience and reduced injuries. This is another study shows that continuous monitoring can increase the lymph node dissection and reduce the chance of nerve injury. In the abdomen, mainly the right gastric epiploic artery is the main supply of the conduit, so it can be damaged, so it's a catastrophe. Either you can repair or you have to consider colon transposition. Again, avoid grasping the pedicle, avoid constriction of the hiatus when you do a pull-up. These are the methods to prevent. Laceration of the liver and spleen is reported and sometimes end up in splenectomy. Gastric tear can occur, poor handling, thermal injury, bulk grasping. Always you should do bulk grasping, that's what I mentioned. Careful pull-up through the mediastinum, that can also damage. This one occasion I had the drain. The chest drain which is already inserted, if you put inside too much inside, that can attach to that can tag onto the conduit during pull-up and damage. I have a tear of the gastric conduit due to the chest tube. Abdomen, again, the conduit can be, after your division, it can be unviable. It can leak, it can twist, and it can get narrowed at the hiatus. So avoid all these complications. ICG, recently the ICG is the advanced technique to know. During the surgery, you can give 2 ml of ICG and look at the conduit whether it is viable or not. I modified these techniques to the neck also. After pulling up, you can check the same camera you can use during robotic surgery and check the viability in the neck. And there's only 2 occasions where you do ICG has a benefit in esophageal surgery, conduit vascularity and lymph node mapping. And hiatus hernia is one of the complications, delayed complications that also can be controlled by hiatus closure. Again, be careful not to damage the vascularity of the conduit. Neck, recurrent laryngeal nerve is the commonest structure can damaged, and there are multiple mechanisms, traction, thermal damage. Again, monitoring is possible here. Avoid any retractor in the tracheoesophageal groove. and the identification of, actually you can do the maximum dissection in the neck, in the thorax itself, and trace it up. That may prevent the damage. And esophagus can be injured while mobilization, fractal injury. Thank you.